All right. Thanks everyone for joining, and thanks everyone at home for joining as well. I am thrilled to introduce Dr. Kaela Pauly, Doctorate of Physical Therapy and owner of Vestibular Specialist, which is just down the road here. She's been specializing in the treatment of vestibular rehabilitation since 2016, and she's been combining her orthopedic and vestibular skills to treat a wide variety of balance and dizziness disorders such as, correct me if I get these wrong, cervicogenic dizziness, postural abnormalities or instability, TBIs, and concussion. So we're so excited to have you here. Thanks so much.
Okay. All right. So today I'm going to be talking about the vestibular system and how that impacts cognition. And that was such a nice introduction. So I can probably skip most of this, but again, my name is Kaela. For those of you that don't know me, I am the co-owner of Vestibular Therapy Specialist, and we are a physical therapy clinic that particularly specializes in dizziness and balance disorders. So, overview for today is I want to start first with just describing what is the vestibular system. Most of the time, when I mention the vestibular system, people give me kind of a blank stare. And so I think it's really important we understand what it does, what its function is. We'll look at how the vestibular system actually has quite a intricate connection with our cognitive function. We'll go through the vast connections of the vestibular system. It's amazing how this one part of our brain connects to essentially throughout all other parts of our brain. So there are vast connections. We'll look at the specific cognitive skills that can be impacted when there's an issue with the vestibular system. And then really interestingly, we're going to look at the link between the vestibular system and Alzheimer's and dementia. There's some really promising research coming out with that. And then lastly, we'll talk about treatment. What are the preventative things that you can be doing or think about? So as I mentioned, we're going to start with the vestibular system. Just out of curiosity, when I say that, like how many people know what that is? Have you guys heard of that in here? Okay, we've got one, two, three, four. Oh, that's pretty good. Okay, usually I get one or two. So the vestibular system is essentially a compass that lives inside your brain. You've got one in your right ear and one in your left ear. It's got three canals that we can see in this picture. And how it works is very similar to a compass or gyroscope. So when you move your head or you move your body, fluid is going to move in one of these canals over here. And depending which canal the fluid is moving in and how fast the fluid is moving in the canal is one way that your brain knows where you're moving, what direction you're moving, and what speed you're moving in. Okay. And then again, we've got two of these. So we have two compasses. So its main physical purpose is to give us a sense of balance and direction and orientation in space. So if I zoom into the structure here, a couple things that I want you to note, because this will come back when we talk about cognition. So when I'm talking about the vestibular system, I'm going to really be focusing on the canals. And then we talk about hearing, we're going to focus on the cochlea, or that snail-like structure. So what you'll notice right off the bat is the vestibular system and the hearing system are very close together. Okay, and that's going to be very important. So if something happens to your hearing, something can happen to your vestibular system and vice versa. So diving in a little bit closer to that is there is one nerve that goes from your ear to your brain. And that nerve is shared between your hearing nerve and your balance nerve. So we call it our vestibular cochlear nerve. This anatomical relationship will become really important when we talk about if there's any damage to this nerve, that it's going to damage not just your balance, but it could also potentially damage your hearing. So the purpose of the vestibular system, like I mentioned, it's going to give you balance. It's going to give you sense of direction. It's going to give you an idea of what direction you're moving in, but it has a lot of other physical purposes. It actually helps balance our eyes. So in order for you to know where to move your eyes, you have to know where your head is in space. So if our vestibular system isn't working correctly, one thing that we can see is you can get blurry vision, particularly when you're moving your head through space. It helps stabilize our neck and head, and it helps generate movements in our arms, legs, and spine so that if we sense that we're going to fall, we make a corrective movement. So this is the condition that I was going to talk to you guys about. And this is where most of the research starts to link issues with the vestibular system and cognition. So I'd mentioned that nerve, and you can see in that picture over there. So if anything happens to this nerve, if there's nerve damage, we call it a vestibular hypofunction. And what can happen is you can get viral infections such as COVID or even just common head and cold flus. You can get bacterial infections that will actually attack and damage that nerve. And remember, that nerve not only does balance, but it also does hearing. So you can get balance and hearing loss together. Okay. Often, what we'll see when this happens is people will report being dizzy or having vertigo or spinning. They'll be off balance, blurred vision. And if it's really severe, we can get nausea and vomiting as well. So, some other causes is concussion. So, if we hit our head really hard, these inner ear structures are very fragile. So, it's very easy to damage those structures in concussion. There's a lot of research coming out. And one of the reasons why people might not be getting better with concussion is no one's looking at their vestibular system. So if they're still dizzy, if they're still imbalanced, and no one's looked at their vestibular system, that could potentially explain why symptoms are still going on with concussion. Other conditions or issues that can cause inner ear damage are certain medications, chemos, radiation, and it can also just happen as we age. It's normal for nerves to degrade a little bit as we age, and the inner ear nerve is not excluded from that as well. So again, when I'm talking about hypofunctions, I want you to just think, oh, it's just damage to the inner in the nerve in the inner ear. So I like this picture because, again, it's going to show you that we have two compasses. We have a right compass and a left compass, a right vestibular system and a left vestibular system. When the research talks about brain health and cognition, it's going to talk about a hypofunction or damage in either one ear or both ears. And they cause different cognitive issues. And so it's just important that, and I'll recap that. But if I'm talking about one ear, I'll say unilateral, bilateral for both ears. So how do you know if you have a vestibular issue? And I'll be honest, it's not always very, very common to know. It can actually be a little bit sneaky. Sometimes if you're getting, sudden dizziness or vertigo, it can be pretty obvious there might be an inner ear issue. But other times, if that damage to the nerve is more gradual, the symptoms might be more gradual. Maybe you're noticing your balance is just a little off. You're stumbling around a little bit more. Your depth perception is starting to go off. You're bumping into things. Maybe you're only occasionally dizzy. But if you're starting to notice any sort of decline in your balance and it's kind of gradual, you may want to get your vestibular system looked at. So sometimes it can be obvious, other times it's not so obvious. These are the most common symptoms that we'll experience. Again, any sort of imbalance, blurred vision, spinning, nausea, or vertigo. All right, so I love this slide because it shows you how this little vestibular system, this little guy right here, has vast connections to all different parts of the brain. This is going to be important because then we're going to understand how it can impact so many different layers of our cognition and brain health. And it's not important that we know the exact areas of the brain, but we can see that it affects the deep brain, the brain stem, the really deep structures, and the surface of the brain. So it can have wide impacts on all different aspects of our brain. And what we've started to realize probably in about the last 10 to 15 years is that instead of the vestibular system just being responsible for balance, it has a lot of other purposes as well. It helps us with orientation, navigation, attention span, and memory. So a lot of key brain functions that we need. And I just wanted to bring this attention that when individuals come in and they have vestibular issues, it's not always dizziness and balance. It can also be cognitive. Some people will tell me I'm in a brain fog. I can't multitask anymore. I'm having to focus so hard on keeping my balance. I can't do higher cognitive skills. Confusion, forgetfulness, cognitive issues with cognitive stamina. I can't get through my full workday anymore. I'm just exhausted. So again, huge implications for it's not just about physical symptoms. It can also be about cognitive symptoms and getting your vestibular system looked at as a potential contributor to that. So when we really are digging through the research, there's a couple main cognitive skills that have the strongest amount of research in terms of linking it to the vestibular system. We're going to spend a lot of time talking about how your vestibular system will impact your memory and how there are different types of memory. And we're going to look at attention span, mental rotation, and executive functioning. I want to spend some time going through and defining these terms, not so that you have to memorize them, but just to give you an idea of how basic some of these skills are and how important they are to your day-to-day function. I will go back and, again, it's not a memorization test, so I'll make sure and go back, but I just want to spend some time going through these. So spatial memory. Spatial memory is really understanding where you are in space. It's the ability to use information about space to navigate and find your way around. So, for instance, 2 hours ago, I couldn't find my keys. I could not remember where I put my keys. That part of that is spatial memory. Or where did I put my cell phone? I'm notorious for losing my cell phone as well. So some examples: planning a route, finding your way home from work. That all involves spatial memory. Topographic memory is a specific form of spatial memory. Essentially, what this has to do is understanding your way or different routes in familiar environments. So these are environments that you know very well, like your home or maybe a friend's home, maybe your local grocery store, or maybe your commute to work. I've got, 15 different ways I could drive to work, but I'm able to have an idea of what's the most efficient route, what's the best way to get there. That is topographic memory. Okay. And again, believe it or not, this massively involves your vestibular system, all of these skills. Okay. So I'm just going to start planting the seed now. There's a lot, we're going to talk a lot about spatial memory. And one of the things we see in early cognitive decline or advanced cognitive decline, Alzheimer's and dementia, is people start getting lost, right? They don't know where they are. They don't know where they've put things. It's one of the first signs we see. It's one of the first things that we see also with vestibular issues. Visual spatial memory. So this is very similar to spatial memory. We're just adding vision into it. So essentially what it means is not only are you remembering where things are, you're remembering what they look like. So if I look to the left here on my little bingo sheet, it's not only about knowing the location of the dots, but kind of having an idea of what it looks like so you can replicate it. So I go into my kitchen and I have an idea of where my pots and pans are, where my forks and plates are, how things are kind of organized in the way that they look. Immediate memory. So we're going to make this synonymous with working memory or short-term memory. This is our memory that we're using really in the present moment. So seconds or minutes. So right now you're using your short-term memory to listen to what I'm talking about, driving in your car, listening to music. So huge implications with the vestibular system and our short-term memory as well. And lastly, attention span. So the ability for us to be selective in what we want to pay attention to. All of us have a certain limit to our attention, how much we can multitask. We have selective attention. And again, believe it or not, the vestibular system highly impacts your ability for selective attention specifically. Mental rotation. This is a really interesting one. Because when I was first learning about this just seemed like such an arbitrary skill. I'm like, how is this important? But as I dug more into the research, this is really important. So we're going to revisit this again. It is essentially the ability to look at an object from different angles and understand that it's the same object. Okay. So if you look down here, this is actually the same object. It's just been rotated. Okay. And what we've come to realize is our vestibular system significantly helps us with that ability. And I will go into how we use that on a day-to-day skill. And you'll be surprised because at first I was like, oh, this just seems kind of like a weird mental skill. It doesn't seem that important. It's extremely important. And then lastly, executive functioning. So executive functioning, I just want you to think about is the three basic skills in our brain. This is really, if we had to boil it down to the three basic skills that we need for being successful at work, for planning. These are the three skills that we break it down. Working memory, which we already went over. That's our short-term memory. Cognitive flexibility, just thinking, being flexible in your thinking, being able to problem solve, being adaptable. And then impulse control or inhibition control. Lots of research shows hearing and vestibular system affects all three of these. Okay. So again, by no means do I expect you guys to memorize all of these terms. We will revisit. Did you have a question in the back? Mm-hmm. And weak. Yeah, so the question that was just asked is if you have a vestibular issue, will you experience issues in all of these aspects or just a few? Is that a good way of kind of summarizing it? Yeah, that's a great question. Correct. Typically, with a vestibular issue, it's not going to affect all of these skills. So it's a little bit individualized, and that really has to do with your brain being different than my brain and how we process information. And then also your background, your cognitive background. If I'm working with someone who's maybe a mathematician, historically, they may have really, really good mental rotation and they can compensate for a little bit of vestibular weakness. So it really depends on the individual. It's very individualized. That's one of the reasons why I like vestibular so much is the presentation is unique in each patient. So that's a great question. So the good news is not all of these will be affected. It's usually just a few.
Well,
Mhm.
mean then that we would adjust if there's a potential problem, that we compensate by that problem in other ways in this particular system?
Yeah, so the question that was asked is, and tell me if I'm not rephrasing it right. If there's a vestibular issue, does your brain find a way to compensate for that issue so that you don't have all these problems? Is that correct? Okay. Uh, Really good questions, you guys. Yes. So our brain is neuroplastic, so that means it can learn and it can change and it can adapt. So depending on the extent of damage to the vestibular system, you can teach your brain to compensate. And I'm not going to go too much into that because I have a whole slide on that. You guys are on it. I like it. These are really good questions though. All right, so let's talk about specifically cognition in the vestibular system. We're going to break it down into three categories. I'm going to first talk about how hearing loss, there's a lot of research that shows that unchecked hearing loss for years or decades profoundly impacts cognition. So we're going to go through that because I showed you in the earlier slides how hearing is linked to the vestibular system. They share the same nerve, right? We're going to look at Alzheimer's and dementia and the connection between the susceptibility to developing those conditions due to vestibular damage. And then lastly, we're going to talk about if it's not Alzheimer's or dementia, so just cognitive decline, whether it's mild, moderate, or severe, how that can be accelerated with unchecked vestibular damage as well. So let's start with hearing. So I want to break this down into two hearing systems because that's kind of how the research does it. And I just want it to make sense when we go through it. So our peripheral hearing system is, I want you to just think about it, it's the structures that collect sound and bring it into your brain. So it's going to be your ear canal, the vestibular system with the canals, and then the cochlea. And then the central auditory is essentially your brain. It's the part of your brain that processes sound. And what's really cool about the central auditory system is that we've gotten pretty good. We still have a little bit of ways, but pretty good at understanding where sound waves go into the brain. And all I want you to appreciate with this slide is that when sound goes into your brain, it stimulates a lot of areas in your brain. Okay. So it can have profound impacts on vast areas in your brain. That's all I really, again, we're not going to get too stuck up on the anatomy of it, but it stimulates your brainstem. It stimulates some of the deepest parts of your brain. It stimulates the surface of your brain. Okay. And we're going to I'm kind of hinting at this idea that if you don't use it, you lose it. Okay. So if you don't keep up with your physical fitness, you start to get weak. If you can't hear, parts of the brain start to get weak. We can actually see those change. So what our brain is really doing is it has to identify what the sound is. It has to also ignore ambient sound and determine what's important sound. And then it has to combine sound. So there's actually a lot of cognitive skill going on with that. We take it for granted, but thinking about what you're hearing is actually a high level cognitive skill. So what do we see with hearing loss? What we know is that if you have damage to that vestibular nerve, you often can also have hearing loss. So there's that link that I talked about earlier. What we know, we can see this in functional MRIs as well, is that if you start to lose hearing, even if it's gradual over time, you have to subconsciously work much harder to understand what someone is saying to you. So for instance, maybe you have to start reading their lips. Okay. Or maybe you have to start looking at their body language more because you can't quite understand what they're saying, or you got to really lean in and really make sure they pronunciate. And so it takes much more cognitive effort to listen to that person talk. And because you're putting in more cognitive effort to listen, you have less cognitive effort put into, or less bandwidth to be able to think critically about what they're saying, or what is your response going to be. You have less bandwidth to do that. Okay. And there is a plethora of research. This has been researched a lot over decades and decades, that we actually see brain atrophy with hearing loss. What that means is that your brain actually shrinks. It's losing mass, it's losing volume. And it's not just the parts of your brain that process hearing, it's the whole brain. And that's very significant. Okay. It affects everything. What we start to see is that if you can't hear very well, people will start to socially isolate. It's not fun to go to a party and not be able to understand what people are saying or have to ask people to repeat themselves. It can be a little anxiety provoking. We also know from a psychosocial perspective, social isolation leads to cognitive decline. It's very important that we have human interaction in our life. So hearing, there's physical changes, there's emotional changes, there's mental health changes. And looking specifically at the research, and we could go into lots of different research. I'm going to pick out the ones that I thought were the most interesting. I want to go back to memory. So when we start to lose our hearing, what we'll see is short-term or immediate memory in particular starts to become very affected. And what we'll do is we'll take individuals of the same age, the same gender, relatively the same health. Okay. One of them has age-related hearing loss that has not been treated, and the other person is considered to have normal hearing. Okay. And we will give them, and to make sure that sound or lack of hearing is not having a direct input on this, we'll write out 4 to 5 different words. And then those patients have to recall those words to the test examiner. And what we find is even if hearing is not involved, the people that have hearing loss, their immediate memory is significantly lower than the people that have hearing. Okay. So maybe it's not the hearing, maybe it's just that the hearing is impacting such a vast array of the brain. But either way, it's having a significant impact on memory. We start to see over time reduced speech intelligibility. That's just the ability to articulate and talk clearly. So not only can you start to have a hard time understanding what people are saying, people can start to have a hard time understanding what you're saying. Okay. And if you can't communicate and express your ideas effectively, that absolutely is going to drive cognitive decline. We've already talked about isolation, but one thing I do want to mention is with isolation, we see a lot of reduced social skills. Social skills are a cognitive skill. Being able to relate to people, seeing different perspectives, arguing, agreeing, disagreeing. There's a lot of cognitive skill that's going on there. I wanted to highlight this in red because I found this kind of shocking, but unchecked age-related hearing loss doubles your risk of dementia. That is massive, in my opinion. Yeah, we have a question. Yes. 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 It's not so much about the type of hearing loss, it's if it gets treated or not. So if it goes untreated, and we'll talk about the theories. So I'm going to kind of, oh, sorry, let me repeat the question. So the question was, is the type of hearing loss important? Like if you're a construction worker, you're exposed to loud sounds versus age-related hearing loss, are you still at risk? The answer is yes. So if you're not getting hearing, it doesn't really necessarily matter what the reason is. You're still going to get that brain shrinkage. You're still going to have that increased dementia risk. One more question. Yep. Yep. Yes. Mm-hmm. Yeah. Hearing. Yes. Yeah. So let me try to repeat this. That was because I don't know this fact, but we're finding that it's really interesting that hearing loss profoundly impacts brain health, but in terms of losing your vision, doesn't seem to affect brain health quite as much. 4 times less impactful versus losing hearing. Yeah, that's fascinating. Because vision also has equally vast connections throughout the brain. So I don't know why one is better than you know what I mean? One is more harmful than the other. That could be probably a whole nother research question, but there's something there. That's fascinating. So I want to go into the theories of why we think hearing loss increases dementia. We have the statistics. We know it does. We can see physical changes, but we really want to understand more deeply why. So and I'm going to call it a theory because we're still researching this, okay? So the first one is the sensory deprivation hypothesis. Essentially what this is stating is that if you go long enough without hearing, you're getting reduced sensory input to the brain, you're getting less sound into the brain. And that reduced sensory input causes shrinkage to the brain because we're not stimulating or using those areas. So that's that kind of, if you're not using it, you're going to lose it. phenomena. We see that with all other parts, with our heart, with our muscles, right? So our brain is a muscle. We got to work it. So as mentioned, we see shrinkage of brain regions. Again, it's not just the parts that affect speech. I'm going to go more specifically into what parts because it gets pretty interesting. Another really interesting phenomena that I think is not talked about enough, but we have the research for it. We get remapping of the brain. So what that means is different parts of your brain have specific jobs. So I'll give you an example. There's a part of your brain that is solely devoted to processing visual information. That is the job of that brain or that part of the brain. It's called the visual cortex. And what we see is that when we take functional MRIs of people who have hearing loss, is that parts of their brain, such as your vision, which typically shouldn't be too stimulated with speech. There's some stimulation, but not to the level that we're seeing in individuals. Other parts of their brain are actually changing because they're losing speech. So they're using different parts of their brain possibly to try to adapt. Maybe you're going to be more visually driven during your conversations to see if you can read lips. But the implication of that is that it's changing function to other parts of your brain. And that's why we maybe start to see vast changes in cognition and on multiple levels. And we see this in lots of different regions of the brain. We see this in our frontal lobe, which is our personality. We see people's personalities start to change with hearing loss. We see reduced brain cells. So if you look at the picture over to the left here, the long stringy things, these are called axons, and they send signals. They're essentially what allow your brain to communicate to different parts of the brain. So we start to see less of those. And then these cell bodies, the circular parts, those are the bodies. We also see less of those. So less of these stringy things, less of those, the cell bodies. So in general, just less nerves. Okay. And that's what we think is resulting in that brain shrinkage. So the second theory is called the information degradation theory. It does not have to do with the lack of sound. It more focuses on the cognitive load. Yes. Yes. That is a whole nother separate conversation because they never had. So like we're talking about congenital deafness, like they were born deaf. No, so I'd have to dive a little bit more into that, but we don't see the same risk of Alzheimer's and dementia. And we think it's because those speech pathways were never fully developed in the first place. So there's not this switch or change going on, but great question. So congenital deafness is different. We see a normalized risk for dementia and Alzheimer's. Okay, that's a great question. So this information degradation theory, what it is stating is that because you cognitively are having to work so much harder to understand what people are saying, you don't have the cognitive bandwidth to do other higher cognitive skills. Okay. So again, let's say you're talking about, something quite complicated, taxes. And you're sitting there and you're like, I am catching like every other word that this tax person is saying. You're working so hard to just understand what they're saying. You're going to miss a lot of the content, right? The processing, the critical thinking, or the ability to multitask. Maybe I can kind of look over here while the tax accountant is talking. I can see, the beautiful garden out here. Nope, I have to like look and really pay attention. So you can't multitask. You can't do higher cognitive tasks because too much of your bandwidth is being taken up with the task of trying to understand what information is coming in. And we do see this. We see a pretty notable reduced ability to multitask with people with hearing loss. There's some pretty standardized tests with that as well. Okay, so that's hearing. I want to jump ship a little bit. We're going to look at the vestibular system and cognition. So again, that's more the circles and more of the balance component. Remember again, hearing and the cochlea share that nerve. I love this picture because it shows how that vestibular system, the information about balance goes into the brain and it goes through the whole entire brain. Goes to the deep part of the brain, the middle part of the brain, and the top part of the brain. So same as hearing, it activates a wide array of areas of the brain. So that's why we think we see the same thing with vestibular loss versus hearing is because it just affects so many different parts of the brain. There's such a good connection there. Similar to hearing loss, what we will see is we'll see notable impairments in immediate memory or short-term memory with those recall tests that I talked about earlier. We'll see more impairments in visual spatial cognition. That's more about being able to navigate, find your way. Remember, look at things and understand how they're organized. We see more impairments with vestibular loss versus hearing loss. Okay. So remember, vestibular loss, remember our vestibular system gives us a sense of balance. It lets us know where we are in space. So that kind of makes sense if you think about it, that you're going to have a harder time navigating in space, knowing where you are, balancing, if it's the vestibular system. What's really interesting, there was a really fascinating test. We see particularly navigating in new or unfamiliar environments is really difficult for people with vestibular issues. So we can put a virtual headset on people and we can have them try to, navigate through grocery stores that, we can make up the environment and we'll give them a goal. Hey, you need to go to the dairy section or you need to find the bathroom. And the time it takes for people to be able to organize and get themselves through and they have a vestibular loss is significantly longer than age-related norms and gender-related norms where there's not a known vestibular loss. Impaired spatial memory, kind of what I'm talking about again, navigation, knowing where you are. A couple other interesting cognitive declines that we'll see is decreased attention span. We also notice that this is more pronounced with vestibular loss than hearing loss. I have not heard an explanation for why that is, but just in the research, we see that. Slower processing speed. So kind of going back up to this one, it just takes them longer to do things. It takes them longer to solve problems. It takes them longer to navigate in environments. Okay. And then this impaired mental rotation that I promised was so fascinating. We're going to go to it. Okay. So just a reminder, mental rotation, you can look at one object from different perspectives and angles, and you can tell that it's the same object. Okay. So you're downtown Seattle, you're walking around a building, you have a sense that it's the same building. It just might look different when you go to a different part of the wall. What we know about mental rotation is it's actually people who are really good at this. So people who can solve like Rubik's cubes, they're masters at Tetris, things like that. It's linked with high IQ. And it's also linked with being successful in science fields. Okay, so engineering, technology, mathematics. So I've listed a few, surgeons, architects, aviation. We could even, doesn't sound as high up, but I'd even put lawyers in here. We'll talk about that. So mental rotation is actually really important to higher cognitive skills. So let me give you some day-to-day examples. I was recently traveling and my phone wasn't working and I had to actually go and purchase a map and I was navigating in Europe. Man, it's hard without a cell phone. But I had to take the map and I had to orient the map for it to match up like where I was. That's mental rotation. Okay. Lining that up, figuring out here's that map. How do I orient it? In general, navigating around your home, downtown, you've got to be able to understand how things are shaped around you, right? Packing luggage, fitting things in together, arranging furniture, things you wouldn't think about. But so there's a lot of organizational skill that goes with mental rotation. And mental rotation is one of the biggest cognitive skills that is impacted with vestibular damage. Okay. Again, I can't necessarily tell you why. But on the cognitive test, this one always pops up. We also see this with Alzheimer's and dementia, that really poor mental rotation. Potentially. So can they hear you asking that question? Okay. So we're going to go back to the mental rotation. And I had mentioned that I don't know why the vestibular system impacts mental rotation so much. And your question was that Alzheimer's and dementia or reframe. Okay. Okay. So is the plaque buildup that you get from Alzheimer's affecting the vestibular system, which is therefore affecting mental rotation? Is that your question? We don't know. We don't know if it's causation or correlation. So what I mean by that is where the research is at right now is that what we see is that early cognitive decline and increased risk there is an increased risk with dementia and Alzheimer's if you have a vestibular condition, but we don't know if the vestibular damage actually causes it. Does that make sense? Or if the widespread plaques are damaging some of the more central parts of the vestibular system. Could be both. We just, yeah, we don't know. I would love to know the answer to that, though. That's where we're going, what we're trying to figure out. So continuing on with vestibular hypofunctions, again, that's just damage to that nerve. Really interesting. What we know with vestibular conditions is that there is a high correlation and causation with causing exacerbated mental health, like pre-existing mental health issues, or creating new mental health issues. So what we will see is that there's a high incidence of anxiety and depression with vestibular conditions. Part of this makes sense if you think about it. If you are not balancing well, it's very logical that you could start to develop anxiety and fear about falling, or you can start to get scared with movement. So you can develop movement-based anxiety disorders. And it can turn into this cyclical cycle of, oh my gosh, I'm so dizzy. And I don't know if you guys have been dizzy, but when you're dizzy, it's extremely stressful. It's a horrible feeling, being nauseous, dizzy, and vertigo. So the symptoms can give you anxiety and stress. Anxiety and stress can actually make you more dizzy. We can think about panic attacks. Panic attacks have very similar presentation to vestibular issues, lightheadedness, faintiness, even passing out, spinning, and dizziness. That can therefore further increase the anxiety, and we get this cognitive. We get this cycle. So what we know with mental health conditions, with anxiety and depression, is we also know that those reduce attention span, processing speed, and memory. A great example of this is if you have test anxiety. You're not going to perform very well on that test if your anxiety is a 10 out of 10. But if we can even bring it down a little bit, your cognitive performance is going to go up quite a bit. So this is well known in the research that about 50% of vestibular patients, which is a lot, will develop an anxiety or depression disorder that is new because of the vestibular condition, or they will report, I've had anxiety or depression for a long period of my life, but boy, it's really exacerbated it. Okay. So I love this diagram because we can start to see the interconnectedness here. Vestibular disorders can make you anxious and stressed. Anxiety and stress can make you not sleep very well. If you don't sleep very well, that can give you mood disorders. It can go back and forth, right? So not only is it the vestibular condition that might be affecting your cognition, it could be the side effects, the lack of sleep, and the stress that could be further dampening your cognitive abilities. Okay. All right, so I promised I would talk about the unilateral and bilateral. So you can get damage to your vestibular system in your left ear and your right ear. Okay. And it sounds kind of odd when I say that, but actually this is more common than you think. Certain medications, and again, even if you get a concussion, you get hit on one side, the forces will travel through the skull and can affect both ears. Autoimmune diseases, and then again, age related. So over time, you can just start to get damage in both of those nerves, just like we can start to lose vision in both of our eyes. So with bilateral loss, the cognitive impairments are much more severe. We have a question in the back. Yep. That is such a great question. So the question was, how do autoimmune disorders affect the vestibular system? So the vestibular system, just like other structures in our brain, it relies on getting consistent blood flow. It relies on getting consistent cerebral spinal fluid, or the fluid that kind of circulates around our brain. And so if you have autoimmune disorders that affect circulation, or affect cerebral spinal fluid, it will affect the health of this structure. I will be honest, the research on autoimmune and the vestibular system is very new, and there's a lot that we don't know. But what we do know is that changes to circulation can cause damage to the ear. Things like diabetes, hypertension, cholesterol, metabolic disorders, skin disorders, anything that, again, affects pressure or circulation in the ear will affect that. And there are a lot of autoimmune disorders that do that. I wish I could be more specific, but there is not. They're actually starting to come up with new autoimmune disorders specifically for the vestibular system. We're not quite there yet. So that's why I'm not giving you specific autoimmune, because the research isn't quite there yet. So I wish I could be more specific, but I will tell you from what I see in clinic, with like hypermobility conditions, rheumatoid arthritis, psoriatic arthritis, Hashimoto's, other conditions that we don't fully understand, these patients have higher risk of vestibular, and we don't quite understand why. Maybe it's correlation, maybe it's causation.
I imagine inflammation plays a big role.
Yes, thank you. Thank you. Inflammation plays a massive role because you can get an inflamed nerve, and that absolutely can damage. Yes, thank you. That is 100% correct. chemo, autoimmune, age. Yep, absolutely. And so what we see when there's damage in both areas is we see much more profound visual spatial processing issues. These patients get lost really easily. Like I'll have patients the first time they'll try to come to my clinic and they have a bilateral weakness. They will give themselves over an hour to try to find a clinic that's like 15 minutes from their house. It's just really hard for these patients to navigate, particularly to new places. Really interesting. I'm going to show you a next slide. There is a part of the brain called the hippocampus. Specifically with bilateral loss, we see shrinkage in this part of the brain. The reason this is so important is that is a biomarker for Alzheimer's. That is one of the biomarkers that we diagnose Alzheimer's with. Okay. We see greater dysfunction in executive function. So just as a reminder, these were the three things. So immediate memory, okay, impulse control, flexible thinking. If something isn't working, can I look at this from a different perspective? Can I try something different? It's much more difficult for these bilateral vestibular patients to do that. So as I promised, here's the slide. This yellow structure, that's our hippocampus. It's a really deep structure inside of our brain. And it is very important for learning and for memory formation. It's important for short-term and long-term memory. And it's really important for spatial memory. And again, this is one of the first areas that we really can see structural change with our Alzheimer's patients. And we see it with our bilateral patients. So this is the strongest research that's coming out recently, suggesting that if we can get to these patients sooner, could we actually do something preventative? Okay, because we'll talk about if we give people hearing aids, it is preventative. So is the same thing true of vestibular? It looks promising, but we don't quite know yet. All right, so dementia and vestibular function. So I'm going to just point this out. One of the greatest things that you could do to reduce your risk of dementia is if you have hearing loss and you feel like it's affecting you, go get hearing aids. Just go and do it. I know they're not maybe the sexiest thing in the world, but from what I've seen yeah, hey, I love that. We had someone here, they think it is sexy. Yeah. 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 Yep. Yeah. Cognition is sexy. Absolutely. And the one thing that I'm going to point out is you would think that most people know when they have hearing loss. You would be shocked. There are a lot of people walking around like, oh, I hear just fine. I'm like, when's the last time you got a hearing test? Oh, I've never had one. And they have significant hearing loss. And it's because hearing loss, similar to vestibular loss, it can happen super gradually that you get kind of used to it. Okay, so you might not realize that you have vestibular damage and hearing loss because you've just adapted to it, which is great. Your brain can adapt to some extent. But I can't tell you how many times I'll be talking with someone and I can tell that they're having a hard time hearing and I've never had my hearing checked. I'm like, okay, well, maybe we should do that. So it's something to really, really consider. Interesting to note that the first sign of dementia in Alzheimer's before we see physical changes in the brain is visual spatial skills start to get compromised. I'm not remembering that person. So that's that visual memory, right? I'm not remembering where I'm putting things. I'm not remembering conversations that I had. And some people say, I don't know how I got here. I don't, those are the things that distinguish mild to moderate cognitive decline to advanced Alzheimer's and dementia. Okay. It's not just simply about forgetting where you put your phone. I do that all the time. It's really about starting to not be able to navigate through the world. And the things and people that are close to you, you start forgetting those things. That's really the difference with like Alzheimer's and dementia. So this is where we're going with the research. The theory that vestibular loss could also be a modifiable risk factor for dementia and Alzheimer's. Again, there's some promising research. I'll show you it, but we're not quite there yet. So is it possible that if we detect early vestibular loss and we get these people into vestibular rehab and we work on their visual spatial skills and we work on their balance and we restore their hearing, does it prevent, which would be awesome, or does it at least prolong quality of life? Either of those would be good things, right? We don't know if it would heal it or prevent it fully, but even if we can extend quality of care, to me, that's a win because right now we need to provide something for these patients. So similar theories here. with hearing loss causing dementia and vestibular loss. So the cognitive load hypothesis, they have slightly different names, but it's pretty much the same thing. You're working too hard to understand people. Okay. So in this case, you're working too hard to balance yourself. It's hard to do other higher executive skills. If you're going on a walk with your friend and you have to look at them, you got to turn your head and you have to balance. That's a vestibular skill. And you're working harder to balance. It's going to be harder for you to be engaged in that conversation. Deprivation hypothesis, same thing. If you're not getting that vestibular input, we know lack of sensory information causes brain shrinkage. So is it the lack of vestibular input that's accelerating brain atrophy, therefore leading to a higher risk? And again, the greatest, strongest research link is that biomarker of Alzheimer's disease with the shrinkage of hippocampus. We're seeing it in our bilateral vestibular patients. They're the psychosocial. We talked about this social isolation. Okay, I'm pretty comfortable in saying that this is not more of a theory. We've seen this social isolation in general. So whether it's vestibular, whether it's hearing, whatever it is, social isolation is going to lead to cognitive decline. So what do we do about all of this? Have an appreciation that your ears are really important to your cognition and you need to take care of them. Okay. So there is a study where we took people with chronic dizziness, we ran them through a course of vestibular rehab, and we actually saw improvements in visual spatial cognition, attention, and executive functioning. Super promising, right? Because these are the skills that we first see start to go with Alzheimer's and dementia. So boy, if I can keep those skills, to me, that shows there might be some resilience that we could build there. Vestibular rehab. A lot of people have no idea what this is. It's a specific form of PT. It's designed to not only restore your balance, but to strengthen your senses. Okay. We do that through three ways. Adaptation. Someone asked a question about this earlier. Your brain can adapt to damage to your ear. The good news is you have two ears. You can actually teach your brain to pay more attention to the ear that's working, but you have to train that skill. Habituation. If there are certain movements that are making us dizzy, if we do them over and over again, we can get your brain to actually not be as dizzy to those movements, and therefore you can be more balanced. And then lastly, compensation. Can I strengthen your other senses? Okay, maybe you're not going to get as much vision. Maybe you're not going to get as much vestibular input, but your sense of touch looks great. Your vision still looks pretty good. Your joints are moving pretty good. So boy, let's keep your brain, getting enriched with sensory information. So this is how we balance. We use all of our senses, our ears, our eyes, our sense of touch, and our joint movement. So this is where we can train in PT. We can identify what those weaknesses are, and then I can give you exercises to stimulate those systems. So few examples of exercises. My one thing I just want to encourage you guys is if you guys are doing balance work, that's awesome, but don't visually fixate the whole time. You're just doing your vision. What about these other systems? So close your eyes and balance. People love to balance on one leg. That's great. But could you move your head? Now you've got your vestibular system. We're moving those canals. So think outside of the box, move your head, close your eyes, stand on different surfaces to make sure you're engaging everything, not just visually fixating. So again, what do we do about it? Go and see your local vestibular therapist. There's not many of us, but we do exist. Move your body, exercise. Everyone always says that. It keeps you stimulus rich. Play games, socialize. Okay. When we're getting depressed and anxious, we want to kind of come in, kind of push yourself to socialize. Stress management, because I talked about mental health and how it does the same thing, right? So none of these are groundbreaking. Most people know, okay, nutrition and sleep and stress management and exercise. The one that I really want to point out is hearing and vestibular, because that's not well known. Please get your hearing checked. Even if you think you have fine hearing, just go get your hearing checked. Even if you're young, go get your hearing checked. I'm almost done, and then we'll do questions. Go get your hearing checked. This is absolutely fascinating. I'm going to round this up to 10% because I think the number sounds better, but 8 to 10% of dementia cases around the world can be linked to unchecked hearing loss. And people go, well, how do we know that? So what we do is we take a large group of people. We know certain things like cardiovascular health, low socioeconomic status, vestibular hearing. We know those are linked to higher dementia. So what we'll do is we'll look at patients that have had those other modifiable risk factors treated, accept their hearing or accept their vestibular loss, and then we track their outcomes. Okay, so we did that with hearing loss, people who eventually developed dementia who didn't get their hearing checked. Those who did get their hearing and then also got dementia, we still saw a much higher rate. That's 10%. 1 in 10, that's pretty significant in my opinion. So healthy hearing, healthy brain. Okay, hearing aids. Only a third of people who are eligible for them will use hearing aids. That's somewhat heartbreaking to me. 30%, that's so low. Okay, so I hope after today, if that's something you've thought about, you should do that. You should absolutely do that. So that's what I have for you guys. Thank you guys so much. And then what we'll do is we'll open up to some questions. Okay. Online or online or in person? What do you want to do first? There was one back here. Let's do your question. Okay. It's great. The questions have been really intriguing, actually. So, no, it's not that you're damaging those parts, it's that they're not getting stimulated. So the nerves that the vestibular input would go to your hippocampus, for instance. If it's not getting stimulated, it's not getting used. It's kind of like if you don't use a muscle, it kind of weakens away. So it's not that you're necessarily damaging the part of the brain that processes sound, you're just not using it, you're not stimulating it. And that disuse causes damage or a shrinkage and damage. Mhm. Mhm. So the question is kind of reverse. So if the parts of your area the parts of the brain that we talked about were affected by the vestibular system, if you go and improve those skills, like social skills, does that improve your vestibular system? Did I summarize your question right? We don't have research on that. I have not come across an article that looks at specifically, for instance, like social engagement directly stimulating the vestibular system. But this is what I will tell you. When you go out and about into the world and you go to a party or you go to a restaurant or you go to a bar, you are stimulating your vestibular system because you have to navigate around things. When you're turning your head to look at conversations, you're engaging your vestibular system. So I would argue clinically that by going out into the world and doing your social skills, yes, you are also stimulating your senses, your sense of sound, your sense of movement. But I don't have a research article that looks directly like that. But I will tell you from clinical experience, I always tell my patients to get out and do something social if they're starting to really, seclude themselves. And what I will say anecdotally and clinically is that I see physical improvement as well. I don't know if that's placebo. I don't care. If it gets them better, I want them to get better. Right? Yeah. Yep. Comments. Sure. And can they hear that or do I need to repeat it when you say? So what's the most common symptom that I see in the clinic with our vestibular patients? Probably the most common would be dizziness. So dizziness is a umbrella term. It essentially means that there is an internal sensation of imbalance or disequilibrium. Something feels off. It could be woozy. It could be lightheaded, heavy-headed. Some people describe it as like a drunken sensation. So by and far, I would say dizziness. And then if I had to go like top three, I would say dizziness. Then the second one is physical imbalance. Like people will tell me, I'm feeling tippy. I'm feeling veery. I feel like I'm swaying. And then the third one I would say is vertigo or a false sense of movement. So it's not always spinning. Sometimes people say they feel like they're rocking or swaying on a boat or tipping, but those would be the top three. Yep. Yep. Yes. I love that. So the question was, what role does mindfulness play into all of this? Okay. So I didn't go into this too much just because there's so much I wanted to cover, but I wanted to get to the nut and bolts today. But I mentioned that the vestibular system has connections with stress. We talked a little bit about mental health, right? So when our balance is off, it is instinctual for our brain to create anxiety because it doesn't want you to fall and hurt yourself. It also really doesn't want you to fall and hurt your head and get a concussion. So the brain will actually start to create anxiety or fear or caution in an effort to reduce your risk of falling. Does that make sense? Okay. So there's the center of the brain called our amygdala, and it's the part of our brain that processes fear. We know there are direct connections between the amygdala and the vestibular system and the amygdala. So if you have a vestibular injury and you're starting to get really fearful and anxious, the anxiety in itself can make you dizzy. The anxiety in itself can actually make you more likely to fall because you get rigid and stiff. And so if you can meditate, if you can breathe, if you can bring down that fear response, you can actually bring down some of the dizziness. And you can maybe avoid some of the social isolation because you're not going to be as fearful to move. So if you can stay calm and work through it, it massively accelerates your recovery. And that's one of the reasons why we think that the patients we see in the clinic that are struggling to get better are patients that are typically have anxiety issues. The patients I don't see in the clinic, they're like, oh yeah, I had a really bad vestibular issue. I meditated and I breathed through it. I healed. They were calm, and your brain can retrain. It can adapt, but it has to be calm to do that. It can't be in flight or panic to do that. Yes. So, yep. Yep. He was spinning. Yeah. You had positional vertigo. Yep. 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 So positional vertigo is a temporary issue, meaning it's not a long-lasting condition. It can usually last seconds to minutes, or you can have sometimes it's called like a hangover effect from it for about a day, but it's these crystals in your ear and they will naturally dissolve on their own. Once the crystal dissolves, your issue is gone. So sometimes people can kind of wait it out. And if you just stay calm and you wait it out, you're okay. Other times, sometimes people, it takes them much longer to break down the crystals, and then they have to come into the clinic and see us. So mental health, mindfulness, present, like is massive. And that's one of the reasons why we think when we see individuals with chronic dizziness, there's there's chronic pain. There's a condition called 3PD. It's chronic dizziness. A vast majority of those patients have an anxiety-related disorder. And it's the anxiety, not always, but a lot, it can be the anxiety-related disorder that is preventing them from healing. Not the vestibular disorder anymore. It's the anxiety-related disorder. It's the change in the network and how they're processing, and everything is kind of startling and scaring them, and they're not moving around as much. And they don't want to be social. They don't feel safe. And then everything kind of starts to go downhill. So it's massive. A lot of my job is reassuring patients it's going to be okay. It's going to be uncomfortable, but it's going to be okay. That's probably 75% of my job, to be honest. And I love that. I love giving people that reassurance. So that's a great question. Yes.
Break off.
Yeah. So what causes the ear crystals to break off? Everyone loves to talk about BPV. I should have added slides, but my timing didn't quite have time. So positional vertigo, it has this horribly long acronym, BPPV, benign positional paroxysmal vertigo. Benign, it's not going to kill you. P, it's triggered in certain positions. Paroxysmal, it comes on suddenly and then goes away. And then the V is for vertigo. It just describes the symptoms. So these crystals live inside our ear. They have a very complex function, but we all have them. And just like every other cell in our body, these crystals, they die off and they flake off of this sticky membrane. So just like my skin flakes off, I lay down new skin, it's usually not a problem. So about every 24 days, these crystals are flaking off in your ear and they dissolve in the fluid and you lay down new crystals. But every once in a while, with a little bit of bad luck, one of those crystals flakes off. You're lying down in bed and gravity does its thing and pulls the crystal into one of those canals. So remember I showed you earlier, remember, I was like, if I can, hopefully it's not too far back. Here we go. Okay. So if a crystal gets into one of these canals, remember your canals tell you how you're moving. So if you get a crystal in here and it's moving the fluid around, it's going to feel like you're moving and then you're going to spin. So that's why people are like, oh, I'm spinning around. So, and what we do know is that as we age, our metabolism slows down a little bit. And so it takes longer to break down those crystals. And so what we'll typically see, not always, what we'll typically see is people will start to get this positional vertigo when they're age 55 and older. You can also, if you get hit in the head really hard, that can knock loose these crystals. And so you can get it traumatically as well. Yes, question in the back. So the question is there a link with being on like a roller coaster ride and having the crystals break off? It's possible. More likely what you're experiencing is motion sickness. not the crystals, not the crystals. So motion sickness is different. Motion sickness is a central vestibular issue. So when you're on a roller coaster, man, you're moving around, right? You're getting a ton of vestibular input to your brain. The fluid is going crazy. Some brains are more sensitive to vestibular input than others. Brains that are more sensitive to vestibular inputs tend to be more sensitive to motion and tend to be more prone to motion sickness. So it can be genetic. So a lot of times they're like, oh yeah, my mom gets motion sickness, I get motion sickness, my etc. So it's just genetically how your brain responds to high levels of vestibular input. That's why not everyone can be an astronaut, because some brain, and I have other people, they can go on roller coasters and tip upside down and they're fine. But it's not because they're not getting crystals. It's just the way that their brain is comfortable with that high level of stimulation. It's kind of like you're getting overstimulated vestibularly. Yeah, motion sickness is terrible. Not fun at all. Yes. Oh, calcium carbonate. So this is a great time for me to plug this. Calcium and vitamin D. So we live in the Pacific Northwest. Please take vitamin D supplementation, unless you've specifically been told not to by your doctor. If there's some sort of weird thing. So low levels of vitamin D or low levels of calcium cause these crystals to not form correctly. So they're kind of in a weakened state and they can break off and die quicker. And so that is one thing that we can do to prevent positional vertigo, is making sure that you always get your vitamin D and calcium levels checked. And I don't know why we're not doing this in the States, but at your annual exam, you should always advocate for your calcium and vitamin D to get checked, because they don't do it. Especially here, vitamin D deficiency is a real deal. Yeah, so specifically in the Pacific Northwest, if you go to other parts of the country that get more sun, they recommend 1,000 to 2,000 international units. There's research coming out here that says we need 5,000 to 10,000. It's a lot more. That's great. You're probably just fine. You're probably just fine. I would recommend if that's a high dose of vitamin D, you're probably fine, but you can get too high levels of toxic vitamin D. So I would just, if you're taking that high level, I would just get your levels checked. Again, it's probably fine. You need an astronomical amount of vitamin D for it to be toxic, but I would get it checked if you're taking that high dosage, just to make sure. Yes. Yeah.
Cycle where thereby
Accelerating, yeah. So the question was, when you see individuals that have balance issues and they're self-limiting themselves, can that self-limitation kind of expedite the balance issue? Is that correct? Or the kind of the overall decline? Yes. That's why the mental health component is so critical. The anxiety, the depression with movement, right? If movement starts to not feel good, we got to figure out why, because maintaining movement is everything. So if you stop moving, you stop stimulating your vestibular system, you stop stimulating your muscles, your tendons, your joints, your sense, you stop stimulating everything, to be quite frank. And if we don't stimulate, it shrinks, it weakens. So self-limiting behavior is something I will often have to address in the clinic. And I tell people it can start with sitting up and down out of a chair, walking around your home. We can start so simple and build up. Everyone can do movement. I'm a big believer in that. You can always modify movement. I've got patients in wheelchairs that are insanely active. No problem. Walkers, cane, you can move. We can always get people to move. Nordic walking. I love the walking poles. Love it. When I do my hikes, I use my walking poles. Absolutely. Yeah. Yes. Okay. So question is, have you seen research or things in clinic that can improve motion sickness? Yes. Vestibular rehab. So there's actually a lot of articles on motion sickness. So what we know with individuals with motion sickness, there is a high propensity to overuse their visual system for balance. So what I mean by that is a lot of times people get motion sick when they sit in the back of the car. They're like, oh my God, I don't want to be in the back of the car. Don't put me in the back of the van or the bus. And part of that reason is when we put you in the back seat, your horizon is obstructed, right? You can't necessarily see where you're going. So a lot of my motion sickness people, they're like, I got to drive. I got to have like, or sit in the front. I need a clear view. We can train your brain by upregulating these other systems. Yeah, there we go. So if we make your vestibular system stronger, your sense of touch and proprioception stronger, you can actually start to be less reliant on your vision, and we can reduce your motion sickness. We don't always eliminate it because there is somewhat of a genetic component, but you can significantly reduce it. And that's where these sort of exercises, and it's fascinating because people will come into the clinic and I can actually reproduce their motion sickness. Sometimes when I make them stand on a Bosu ball and close their eyes, they don't like the rock because they can't see it. We can desensitize your brain to that. Yep. And the other thing that I would say is be really careful with motion sickness medications. If you take those medications on a super consistent basis, the reason you feel better is because it suppresses all of these systems. Similar to alcohol, it's a suppressant. So you're not getting that sensory information. So therefore you can't be reactive to it. But then you also can't retrain your brain. And you're teaching your brain when in motion that you need to suppress. That's actually not correct. You actually need to upregulate these other systems. So wrong use of motion sickness medications is problematic. Vestibular rehab is really where you want to go. And then managing migraines. Unmanaged migraines create elevated motion sickness. So those would be the three areas I would focus on. Yep. Yes. That's a tricky question. So the question was, what does tinnitus or tinnitus have to do with the vestibular system? And so for those of you that aren't familiar with tinnitus, it's essentially ear ringing. That is a huge gap. We still to this day do not fully understand where tinnitus is coming from. Okay. So we know that damage to that vestibular nerve or cochlear nerve, there's correlations that can cause tinnitus, but we actually truly don't know the mechanism of what's going on with that. So it's a little bit unknown. There are theories that it's actually not necessarily an ear issue, but a brain issue. It's the part of your brain that processes sound is overstimulated. You're kind of stuck in a loop. And so this can happen with other things, for instance, such as anxiety. People get stuck in like anxious loops. So it's this loop of nerves that isn't turning off. And there's an inhibition issue. There should be a nerve that turns that off. And that's not happening. So it's either a central auditory issue, when we went back to the slide, or we do know damage to the inner ear, like if you're exposed to loud sounds, construction workers, or if you're a veteran, you're exposed to, guns, bombs going off, that the damage to the cochlea can cause repetitive sound as well. But we're not, I'll be honest, that is a weak spot. We're still not very good at treating tinnitus. We really don't understand it. So sometimes you can mask it. So we'll figure out the exact pitch and frequency of that sound, and we'll put in a hearing aid that creates the exact same pitch and hearing sound to cancel it out. So sometimes that works, sometimes it doesn't. So I know that's not a very fulfilling answer, but the fulfilling answer is we don't know. Yeah. Yep. Mm-hmm. Mm-hmm. Yeah. So the question was, have I read about or heard anything about spontaneous tinnitus or spontaneous ear ringing? Yes. In fact, I want to normalize that. If you occasionally have like a ringing, because I have this, sometimes it's like, and then it goes away. And it's like not a big deal, right? It'll last for seconds or a minute. We know that nerves are spontaneously activated. Okay. And so you can get some spontaneous activation of your vestibular cochlear nerve, and our brain will process that as sound. It's not a big deal. It's totally benign as long as it's here and there. So I've got tinnitus. It'll just pop up, I don't know, a handful of times a year. And I'm always like, oh, that's absolutely fascinating. I kind of tune into it a little bit. What we do know is that if you focus on the tinnitus, so I've got some patients like, it's driving me mad. It's the only thing I can think about. If you focus on it, you're telling your brain that it's important, and your brain will go, oh, I'm going to exert more brain power to pay attention to that. And you can increase the volume of your tinnitus. So it sounds absolutely ridiculous and preposterous, but sometimes what we have to tell people is like, don't get anxious about it. Don't worry about it. And that will actually start to tune it down. Tell your brain it's not important. You don't need to pay attention to that. So there can be a psychosocial component to it as well. But I don't think that explains all tinnitus by any means. So, yep. These are such good questions. Okay, like these are really, yeah, these are fascinating. These are questions I have as well. It's particularly with tinnitus. I really wish we had better management of that. Yeah. Okay. Mm-hmm. Mm-hmm. Healed. Yeah. Uh-huh. 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 Yeah. 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 So the question was individuals that have had multiple concussions are susceptible to like bumping their head again and almost sometimes re-experiencing symptoms. And is there a connection to the vestibular system with this? The answer is yes and no. So here's the yes. There are different subclassifications of concussion. So some concussions affect more of mood. Some concussions affect more of vestibular. There's traumatic headache. So there's like different subcategories of concussion. So there's a whole sort of concussion that affects or damages the vestibular system. And if you do get significant damage, you can be susceptible to not having as good of visual, spatial, and spatial memory and balance. And so you could be at a higher risk of literally falling and bumping your head again. So in that sense, yes, it could cause you to be at a higher risk to get concussions again. The other thing that we know in general, just with concussion, is the more times you get concussed, the easier it is to get a concussion. So I'll have some patients that are like, I stood up from my car and I bumped my head, and it's not a huge hit, but they're like, it set me all the way back. I'm like, I'm back in it. And you're like, what is going on with that? And to be honest, I don't know if I'm going to give you a very thorough or satisfying answer on that, but we do know it's a thing. One speculation is that there's a protective mechanism going on. Okay, that your brain is our most vital organ. It consumes the most energy. It is what makes us us. It's what makes us human, right? And so your brain can actually start to be hypervigilant or more sensitive to vibration or bump. And when you get that bump or vibration, it will purposely trigger symptoms to get you to shut down so that you recover and that you don't keep pushing. So part of it can be a survival mechanism that is actually kicking in as well. Does that make sense? And then also we know with concussion, it causes metabolic changes. So the way that you consume things like glucose, the way that you make neurotransmitters, if some of those irregularities are never improved and you bump your head again, your ability to heal from a brain injury is compromised. Maybe your blood flow is not as good as it should be. Maybe your glucose consumption is off. Your metabolism is off. So if you do take a little hit that shouldn't be a big deal, it's now a big deal because we haven't really diagnosed or treated an underlying physiologic issue from the first or second or third concussion. So that's what, that would be my answer there. Do you have anything to add to that? I mean, I'm just curious. I mean, okay. Yeah. Yes. Overactive microglia. Yeah. Yep.
That eventually, hopefully, with
Yep. Boom. Full response. Yep. All the symptoms. Yep. So that's my thing is it protective? Is it their vestibular system just makes their balance off? Is it reactive, or is there an underlying metabolic issue that has been off in that brain since that concussion so that it just can never heal as quickly as it should? And that's really where we need to go, is we need to figure out metabolically what is different with these brains, because we're missing something that makes people vulnerable. And that's why it's so important to obviously prevent repetitive head trauma, because we're not at a point to be able to clearly identify that. We're getting there, but there's still a lot of work. How is it consuming oxygen? What is it doing with carbon dioxide? What is it doing with glucose? What is it, we don't know. We don't know, quite frankly. So, prevention is obviously the best medicine, but life doesn't always allow that either. So, yeah, that's a great question. Yeah, a question in the back. Oh man, that's such a good. So the question is, how do you test the brain's metabolism? It's very difficult, and I will be honest, that is not my job, and I do not do that. I do work with a couple neurologists that actually do that, and you might have better answers than I do. There is a lot of blood work that you can look at as well that like looks at how you're regulating your glucose levels, looks at your glucose consumption, looks at your oxygen and carbon dioxide levels. You can look at cerebral spinal fluids. So more extreme examples, and you can do things like spinal taps. Functional MRIs are helpful in like how your brain is actually firing. That's about the extent of my knowledge of that, because I will be honest, I do not do that. And when I feel like there's an underlying metabolic issue, I refer them out to the autonomic doctors or the neurologists, and I have them, or endocrinologists sometimes too. You can see like what your adrenal glands are doing, what your thyroid is doing. That gives you insight into the chemicals in your brain as well. And newly, looking at your gut. Looking at your gut will tell you what's going on with your brain as well. I won't get too into that because that's totally out of my scope. But that's it. Do you have anything to add to that? Do you have any other tests that you're aware of that look at? Okay. Yeah. Blood testing. Yep. Even image.
The extreme symptoms, but structurally,
Everything's intact. We can't get in there. And there's a blood-brain barrier. There's extra protection around the brain. It's crazy. So really, we look at the blood outside of the brain to see what the blood looks like. What's going into the brain via the blood. That's kind of our best bet. We're working on technology. It's a particular sort of MRI. We haven't quite got there. That's going to eventually allow us to look at. Do you remember the nerves I was showing you guys earlier that had like the cell bodies and the axons? That is what we need to be able to image, not the brain tissue, because unless it's like an extreme open head trauma, usually the brain looks fine, unless there's a brain bleed, but that goes away. It's at the cellular level that the damage is taking place. And so we're looking at tracking, they're looking at in the brain, the way the nerves store water is unique. And so we're looking to see if you can track water droplets along the axons and the cell bodies to see if there's disruptions. Like, oh, like this cell isn't connected anymore. Like this has been torn and sheared. So that's the problem. It's the damage is microscopic, and we can't get in there. So, but we're trying. That's where it's going. Is there a question?
Sure.
Great. Just as you should. Yep.
Sure.
Mhm.
Right, so things
Yep.
on should
Asking for. Yeah, I think so. When you go into your annual exam, they do look at a lot of things, but the two that I'm going to absolutely tell you that you need to ask for is calcium and vitamin D. For women, you need to have them look at your thyroid. They don't do it. You need to your thyroid and adrenals. Those would be the extra things I'd ask for. Naturopaths actually do a much broader blood testing. So like if you really want to like get into it and look at everything, the naturopaths look at all those things that I just talked about. I don't know why the primary care providers won't necessarily look into those things unless there's an issue. And I would like to be looked at before there's an issue. Because all people that are like right on the cusp of like, well, my doctor said I had normal vitamin D. And I'm like, well, let me look at it. And they're like in the 1 percentile of normal. I'm like, that's not normal. Because that's the other thing is like the ranges that we give as normal are massive. So I always tell them like, if your doctor says like, oh, this is fine, you need to look at your labs. And if you're like barely at the end or you're way up here, you need to ask them about that. And then they go, well, yeah, you're right. You're right on the verge. Okay, well, I'd like to do something about it, so I think you have to look at your lab results, unfortunately, and usually they're pretty easy. It will tell you this is normal, this is where you're at. You need to look and see where you're at. And if you're not, if you're in the 1 percentiles, I'm going to say 25 percentile, the bottom, or in that, upper 25 percentile, you need to start looking at that. And I'll be honest, what I do, I'm a little neurotic about it because I've seen this, is I'll look at my lab values year to year and I'm like, oh crap, every year this is moving up. Okay, I want to do something about this now. That is not the way Western medicine is working right now. The way Western medicine is working is you're outside of the norm. We will now give you medication. We'll now do this. So naturopath. I'm very happy. They're like, oh, no, we need to be proactive, or this isn't optimized. I'm kind of more about optimization, right? So that would be my best recommendation. There are some fantastic primary care doctors out there that if you just ask, but the big ones are calcium and vitamin D, and then for women, thyroid. That's what I would ask. Yeah, that's a really good question. Optimization, exactly. Not being reactive, being proactive is always what I want to do with my health, what I want to do with my patients. So it does require more engagement on your part to look at your tests and ask your provider. I tell people all the time, ask them to explain it to you. Yeah. Yeah, you do. You do have to be the advocate. And that's just, that is the way that it is for sure. Yeah. Question.
um, um, poor performance by it and issues like schizophrenia.
Okay. So the question is there any connection with the vestibular system and schizophrenia specifically? No, I have not read any research that shows a link between schizophrenia and vestibular, but there are links with other conditions such as OCD, anxiety, and depression, sleep disorders. Those are the ones that have the strongest research. There also are connections with learning disabilities, particularly in children. So for instance, I haven't worked with children in a while, but there's a general, so there are these motor milestones that you're supposed to hit as a child, like, okay, we crawl, then we walk. Vestibular damage will absolutely slow that and can sometimes have some cognitive implications in the school. But no, I haven't seen anything with schizophrenia. I'm curious, what's your connection there with that? Or okay. Yeah.
Challenges.
Oh, interesting. Okay. So the question is, do individuals with schizophrenia have vestibular challenges more so than someone who doesn't have schizophrenia? The difficult part with that is we do know with things like schizophrenia or bipolar or if someone develops a tic, there are movement disorders wrapped up in those mental health disorders. So we'll sometimes see people like tremor or shake, and it's not a vestibular issue that is necessarily doing that's a separate movement disorder that's caused by a mood disorder. So I'm not going to totally rule it out, but I've not seen any research that looks at that specific correlation, although it is fascinating because there is an erratic movement. There is maybe maybe there are more falls and loss of control, right? We see this with things like, it's different, but with Parkinson's, there's obviously a cognitive component, but there's a movement disorder to it, right? And I'm not an expert in schizophrenia, so I don't know if there's also movement disorders built into schizophrenia and what that looks like, but yeah.
Your answer was interesting to me because
Sure. Collection. Layered on top. Yeah.
Shortfalls.
Yeah. Yeah. So kind of the question is that individuals that often have schizophrenia also have other mental health conditions such as anxiety that you had mentioned. And so if addressing some of those other mental health factors, because we know anxiety and vestibular are linked, could that potentially help? Is that what you're saying? Yeah, I would go that far, because we do know, like I mentioned in my other slide, there's this really notable correlation between anxiety and vestibular disorders. There's this new movement in the mental health community that there is something called physiologic anxiety. So we used to think anxiety was caused by something stressful, or a thinking pattern or a behavior. But what we're actually coming to find is that physical illness can create anxiety. So when you have a vestibular disorder, that can make you anxious, or you have chronic pain and you're uncomfortable, that can make you anxious. It's not necessarily purely mental, it's something physical that's giving you the anxiety. Does that make sense? And so there is this new movement of addressing more of physical conditions to see if it helps with physiologic anxiety. So yeah, I could see that. Obviously with schizophrenia, there's probably an anxiety component to it. Can we make your anxiety better? Is there a vestibular component that's also exacerbating anxiety, which the anxiety is also exacerbating schizophrenia? Sure. I mean, everything can be so layered and interconnected that I wouldn't rule it out, but I just can't say confidently that the research is there. So, but I'm always pretty open-minded to things. So, yeah, interesting, very interesting. Yes. Yes.
Through DNA testing, dominant, not so dominant.
Yeah, like a recessive or dominant trait. Yep.
DNA testing with vestibular system or systems.
Not yet. So the question is there any sort of DNA testing that would look at maybe the susceptibility of developing vestibular disorders? Is that?
Instructed.
Yeah.
The connections.
Yeah. 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 In genetics, yes. So, and there's two components to the vestibular system. We talked about the peripheral system, but there's also a central vestibular system. It's the part of the brain that takes the vestibular input from your ears and combines and balances it. And so we do know, like for motion sickness, I talked about that with some motion sickness, right? We do know things like migraine and motion sickness have a genetic component to them. And we know that migraine and motion sickness involves your central vestibular system. So we have not, to my knowledge, identified genes that necessarily will say you're at risk for that vestibular hypofunction. But if I remember correctly, there are some genetic testing that can look at premature hearing loss and congenital hearing loss. So then there is a connection between hearing loss and vestibular. So it's in the works, but I would say we're not there. I haven't seen anything that like truly links vestibular, but I would be fascinated. But hearing has a little bit more research with that, because some families there are recessive and dominant traits that can lead to complete deafness. So that you could translate that over a little bit to the vestibular system as well. Yeah, great question.
Sorry, I'm playing this.
No, that's good.
To push off the date that you're
Sure. Yeah. I mean, sound exposure, you're going to concerts, or you have a job where you're working on a construction site where you're going to be exposed to loud sounds. You need to have appropriate earplugs, and there are different types of earplugs. So prevention of hearing loss, we didn't talk too much about that. Treatment of hearing loss. If you have hearing loss, getting your hearing restored through hearing aids has a lot of protection cognitively. We talked a lot about that earlier on in the conversation. The other thing that I would argue too, from a vestibular perspective, if you're starting to notice some physical imbalance or dizziness, getting in and working on your vestibular system can potentially be protective. The research is still working on that, but the most modifiable risk factor is avoiding hearing loss or treating hearing loss. That's really those are the easiest things you want to do. And then take your calcium and vitamin D, because we know that also helps with inner ear health. Okay. Don't hear. Sure. Yep. Yeah. Yeah.
So with the hearing loss,
Yep. Yeah, because we talked about that. Like if you're born with deafness, we don't see the same risk as dementia and Alzheimer's. And we think it's because, again, this is somewhat speculative, but we know with like sensory deprivation, we talked about the brain shrinkage. But if you were born that way, you've had to adapt and compensate your whole. Correct. So you're probably still getting a lot of sensory information. It's just less auditory information. You can compensate by increasing other sensories, eyes, sense of touch, vestibular. So if you're born with it, we're not as concerned. But if you what we don't like to see is this rapid brain change because you weren't born with it and it's starting to happen over time and you didn't address it. And so you're having a negative response because your brain is actually changing. That's not your case. You were born that way. Those structures are probably never stimulated like that. So their function has probably been a little bit different from the get-go. You're not remapping and losing and shrinking. You're adapting. Does that make sense? So typically that's why we don't worry about it if you were born with it or if it happens as a child, because it's happening so young before things are fully developed. Your speech processing is going to develop different than someone who has hearing, and that's okay. We don't like to see the rapid change when you lose it. Yep. Does that make sense to me?
Yeah.
Okay. Okay. Yep. 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 You're not going to get the remapping because it already remapped. Do you see what I'm saying? Yeah. Okay. Yep. Anything else? Anyone else? Yep. I don't work here. That's correct. Yep. Yep. I've got my own practice, but we're actually so close to each other. So how long did it take? Like it takes me like 10 minutes or something to get. Yeah. So I'm just up in Northgate. I'm at the Northgate station, but we're a typical physical therapy clinic. So you can just call us up. We take insurance as well. So I've got some of the cards. Yeah. 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 We go back and forth. Yeah. Yeah. So yeah. It's a really nice symbiotic relationship because we'll have patients where I've really pushed them from a vestibular perspective, but maybe we've capped out on progress and we need something different. I need something more focused on changing, the metabolics and getting, these different treatments here that I cannot offer at my clinic. So, and we communicate back and forth. So we'll make sure there's a good continuity of care needed. Yep. Brain fitness. Oh, I know. I'm telling you. I'm telling you. Yeah. 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 Sure. I get that. Absolutely. Yeah. Yeah. I love it. Please. Please do. Yeah. Yeah. We don't do audiograms at our clinic, but there are some fantastic, we actually have a really good ear, nose, and throat and audiologist community in Seattle, like really good. I always tell people when because all people is like, well, I don't want to use the walking stick because I don't like the way that it looks. I'm like, yeah, but you're not walking right now. Like, what if I could like get you to go on a trail and walk outside and get fresh air and you have a walking stick versus you don't get to do that at all because you don't have the walking stick. That's that like self-limiting. But I hear you. Yeah. There's, people have stigmas about that. And I totally get, but I will tell you, like, after what I know now, I get my hearing tested and I will be getting hearing aids just because, and dementia and Alzheimer's also runs in my family. So I will absolutely be getting hearing aids. I don't care if I have to get them next year. From what I know through the research, it's so promising. It's so promising. Yep.